A little bit of context to what I'm going to talk about, and then I'm going to wander in this talk among several things. So the context is, I have been working on the issue of services integration for a long time. And that really dates back to the time when the Surgeon General did the report on mental health. There's another little-known report that you probably don't have, where the Surgeon General did a second report in the year 2000 on integration. Then I was involved in the project that was done by the Institute of Medicine on services integration, crossing the quality chasm. I was their project officer. And more recently, I've been involved in trying to implement this in the Affordable Care Act. So a long history and interest in the issue of how we integrate behavioral health care and primary care, and I would go on these days and say in doing that we also need to be linking this to public health. In Oregon, the community care organizations that are being put in place in response to the Affordable Care Act do include public health. Public health works on a lot of the same issues behavioral health does. Obesity, smoking, and so on. Why would they not be linked in? And in Oregon, they've actually linked them in. And in some places, it also now extends to dental care as well. So I think in behavioral health, we're on the cusp between what I would call the second generation of integration, which is what we've called bidirectional integration, where we put a behavioral health unit with a primary care unit, or we put a primary care unit with a behavioral health unit. We're on our way to the next generation of work, which is full-bore integration. And the paper I've given you was just published a few days ago on fostering sustainable integrated systems. That paper talks about this third generation of work. So what I want to do in the talk here is walk my way into this issue in various ways. I'm going to give you some context. I'm going to give you a little bit on the Affordable Care Act and a little bit where we're likely to be going here as we go forward. So on the title, Health, Behavioral Health, and the WRAP, the reason I call this the WRAP is because we don't quite yet have a WRAP between behavioral health and primary care. And that occurred during our lunch and part of our conversation where we said, well, how are we going to talk to the health systems and what are we going to say? Well, that's exactly the issue of the WRAP here. And we want the WRAP to go on and become a WRAP dance. Do you all know what a WRAP dance is? You do, obviously. So we've begun talking between behavioral health and primary care, and we want to try to move it on to the next generation. So how do we tell that story in a credible way from our own point of view? And then what grand challenges are we going to encounter? Now the word grand challenges is not just a word I put in here. That word has particular meaning these days. So there's a lot of money being put into the problem of what are our grand challenges and how do we solve them. Robert Wood Johnson funds in that area, as do some other foundations. So I'm using that word advisedly here. I also want to mention social justice, and I'm glad David mentioned that. A huge part of what we're talking about here in integrated delivery systems and in the Affordable Care Act is about social justice. So put that into a little syllogism here. So the syllogism would say, and I start with Franklin Roosevelt. Franklin Roosevelt in 1944 did his State of the Union from the White House. Immediately after he did that, he went into his inner office and he recorded a second talk on human rights. The very first human right he talked about was everybody in the United States ought to have the right to good health. Everybody in the United States ought to have the right to good health. Element one. Element two, we value all people equally. We value all people equally. You need to think for yourself how you would actually answer that. Do you actually answer that? Yes, I agree with that. Or do you answer that with reservation? How should the government answer that? Huge issues here. So, everybody ought to have the right to good health. We value all people equally. Therefore, you can do nothing else than the types of things we're doing here in the Affordable Care Act, which is intended to reduce disparities in health and access to health care. There's an underlying syllogism. Most people will not be bold enough to stand up to you and say, I don't value all people equally. Try it. Try it on somebody. See how they react to that. Most people won't be that bold. So there's a huge issue, an underlying current in all of this work of social justice. So what I'm going to do is really 4 levels of things. Do the environmental scan. What is the changing current landscape? What are the emerging solutions and what are the next steps? And I'm going to wander in and out of the history that I just kind of went over and the Affordable Care Act and so on. So the quick history. The Surgeon General's report on mental health, 1998, the basic finding was mental health has a good research base and we know that treatment works. That was the basic finding. However, the final chapter of the book said the next generation of work is we need to move to the integration of mental health and primary care. That was in 1998. Care integration is required. So the next step here, the President's new Freedom Commission on Mental Health. There can be no good health without mental health, and there can be no good mental health without health. Very first principle from the President's new Freedom Commission. The IOM study that I mentioned before, so when we did that study, I was on the mental health side, I partnered with Mady Chalk, who was on the substance abuse side, and we convened the panel, and the panel said, what do you want? We said, we want something practical that we can take out to the field. We want a blueprint for change, not a theoretical treatise on integration. And I think they did a fairly good job, actually. Mary Jane England was the chairperson of that panel. Another part of this is you can't do integration if you start with fewer cards than the person you're playing cards with. So parity is part of giving the same amount of cards to behavioral health that primary care starts with. So we had the Wellstone-Domenici Act in 2008, which defined parity for large private plans, meaning private plans that covered 50 or more people. Theoretically, it also covers Medicaid that's operated by private plans, but there never have been any regulations to this day on that issue. And then the Affordable Care Act actually carries that parity to the next level. Recovery. Part of this is also about recovery here. So it makes no sense to talk about integrating systems if you don't achieve any effects. And very clearly, we can bring the concept of recovery to the table of integration and to the table of the Affordable Care Act. I don't know any other field that talks about recovery the way we do. We could have a long conversation about that. And so then the Affordable Care Act, in effect, brings all of this together in various ways, and we'll try to talk about that as we go forward here. So the policies reflected in the Affordable Care Act that relate here, we're trying to move toward universal insurance coverage. And if I look at the numbers, so the intent here is to cover about 20 million people through the marketplaces and 19 million people through the Medicaid expansion. If you look at the states that are not currently doing the Medicaid expansion, including the state of Pennsylvania, there are about 5.4 million people who are going to become what are called part of the gap population. These are people who aren't going to be fish or fowl. They're not going to have Medicaid, and they're not going to be in the marketplace. 5.4 million. A significant portion of those 5.4 million are in Pennsylvania, and you are leaving $38 billion of federal money on the table by not doing the Medicaid expansion here. So I know the minute you run out of the room here, you're going to be very active in arguing that issue. Pre-existing condition exclusions. So until January 1st, only people up to age 19 could not be denied health insurance because of a pre-existing condition. Starting on January 1st, the Affordable Care Act extended that to everyone who's in this room. You can be 106 years old and have a pre-existing condition and not be excluded from insurance any longer. And that literally just started a few days ago here. Medical and health homes. So the two models here that are really relevant are creating a medical home in a primary care setting, where you integrate behavioral health with primary care, or creating a behavioral health, what's called health home, where you integrate primary care into behavioral health care. And both of those models are viable. Now, if I take those and move them down and say, well, currently where we are is 65% of all behavioral health in the US is given by primary care operations, and 35% is given by behavioral health operations. If I let the Affordable Care Act play out, I would predict it will be 90-10. 90% will be given in primary care settings and 10% will be given in specialty settings. And the specialty settings will become very focused on people who are more severe. And you're already doing many of those things here in Philadelphia, so that should be no great leap for you. The numbers we're talking about aren't going to change dramatically because you have so many more people coming into the system. So as the system sorts, the public system will still be serving about 6 million people like it is today, the public substance abuse system about 2 million. But the bulk of the additions will be going into primary care if you sort it down and do 90-10 basically. Another major feature here is disease prevention, health promotion. Don't have a lot of time to develop that today. I would say that I've done some work on that, and Dr. Kumanika has done some work on that, on the social and physical determinants of health, how the social and physical determinants of health influence your health status, how your health status then determines what kinds of prevention and health promotion interventions you need to have, and how that then influences your subsequent health status. Some classic examples here. So if you tell me you were born poor, you were born in poverty, I'm going to immediately subtract 5 years from your life. If you then tell me you didn't graduate from high school, I'm going to subtract 4 more years from your life. If you then tell me you also got depression when you were 20, I'm going to probably subtract another 5 years from life. I've already taken 14 years off your life just on the basis of those 3 variables. The trick here in the social and physical determinants of health is to move upstream and say, what can I do to intervene with somebody in poverty so that mortality effect does not occur? Huge issue, huge amount of work here. In behavioral health, doing a better job of defining prevention interventions. So if we went around the room and say, what prevention interventions do we know about in mental health right now? The cupboard is pretty bare. We do have SBIRT in substance abuse, but that's kind of a secondary prevention intervention. We don't have much. That is going to need to change dramatically. And also I want to put on the table the concept of positive health promotion. So it isn't just about doing a disease intervention with someone who doesn't currently have a disease. It's how do you promote positive mental health? Who is doing that work? CDC is doing that work. There's a strategic plan in CDC to promote positive mental health, and I'll share that with Christina and she can share that with all of you. So a huge part of the Affordable Care Act is moving some of the money from disease treatment upstream to prevention and promotion, including the social and physical determinants of health, basically. And then finally, achieving recovery and resiliency. We are the only people who deal with recovery, and I would argue most of resiliency, most of prevention actually is behavioral. We're the people who should be doing prevention, but we're not currently doing it. So there's a huge agenda under each one of these things that we could spend a long, long time talking about, basically. And the underlying concepts of the ACA, person-centered care, whole health care, shared decision-making, and so on, are very friendly to us in behavioral health care. There's nothing new there that we haven't thought about and worked on. So there should be a very good fit between behavioral health care and the Affordable Care Act. So some practice developments. Now, in addition to the Affordable Care Act, now we're moving over to the second stage here, we got Medicaid transformations going on in the states. The Medicaid transformations are being done through the 1115 waivers, the purpose of which is to bring the whole system under managed care and to reduce the number of separate programs in the Medicaid system. Virtually every state is about this right now in one way or another. And you have done some of that in Pennsylvania, and I would predict you are going to be doing more of that. The movement toward integrated care. So it probably is not up yet at the tipping point, but it's on its way up, where I can go anywhere in the United States and hear people talk about integrated care and things they're doing. And now the discussion is beginning about integrated financing. So moving from what we have called in this field historically carve-outs, you have a carve-out here, to carve-ins, to integrated financing. And I would argue on integrated financing is very important, particularly for the people who are receiving behavioral health services in primary care, because all the money is on the other side right now. And if you don't solve this other problem, you're still going to be left with this huge set of people over here who have both behavioral health conditions and primary care conditions and get poor quality care and have poor outcomes, basically. So unless we can solve that problem simultaneously, we can't solve our problem only by working in the specialty sector. Obviously, an enduring concern with costs, an emerging concern with wellness and wellness models. So for any of you who worked in behavioral health care, you know that there's a lot of interest in wellness. Where is that coming from? It's coming from peers, absolutely. That did not come from NIMH research. It didn't really start with SAMHSA. It didn't start with CDC. It started with primary consumers. And they said, you know, we're dying 25 years younger than other people. We want to take this seriously, and we need to develop wellness interventions. Peggy Schwarbrick over in New Jersey is a classic example of a person who is very much into wellness interventions. But they're all grassroots. There's no comparability from place to place in wellness, and so on. Could have a very long discussion of that. And finally, output seeking rehabilitation and active community lives. And I know there's been a lot of work in Philadelphia about achieving full community integration of people with behavioral health conditions here. Political development. So what kind of things are going on here? So I'm using the consumer movement has fully come of age. So many of us who've been in the field a while know that it's been a long time in coming. It's come on both sides. The one I have here is the Faces and Voices of Recovery Favor. That's a full national movement. They are at every table nationally where they should be. They make inputs into what the federal budget is, what SAMHSA is doing, what NIMH and NIDA and NIAAA are doing, and so on. Recovery. If you ask people why you come to care, you don't come to care to treat your symptoms. You come to care to live your life, basically. You come to care to live your life. So you come to care to have a life in the community, to have friends, to have a place to live, to have a job, like other people, basically. Affordable Care Act is creating external pressure and financial incentives. So that's just now starting. You're at the opening gate of this process. That's going to continue to ramp up. I would stand here and predict 10 years from now, 2024, we'll be spending 30% of our disease care dollars on these upstream factors, at least. And that'll be forced by what CMS is going to do to the Medicaid and Medicare programs going forward. So if you're trying to go where the system is going, you need to get engaged in a process of research and intervention that where you'll intersect that as that's starting to happen out there. And as I say, behavioral health starts in a weak place on these things. Weakening of the state substance use agencies and the strengthening of the state Medicaid agency. We could say the same thing, weakening of the state mental health agencies and strengthening of the state Medicaid agency. California no longer has either a mental health agency or a substance use agency. Gone completely. I expect that process to continue. So behavioral health traditionally has related to those agencies. We're going to have new state partners. It's going to have to be the state health agencies, the state public health agencies, and so on. Second area, changing landscape. So many of you who deal in epidemiology know these numbers. So if you look at serious mental illness, 20 years ago we defined that as a person having a mental illness and having a serious impact on their life in the community, in their family, and in their employment. So any type of mental illness can qualify. So the critical factor here is not the mental illness, it's the functioning that results from the mental illness. And so we actually had a discussion of this 20 years ago. We said, should we throw mental illness out completely and only talk about functioning? We said we could do that, but then we would have zero credibility because the entire establishment would have rejected what we were doing. So we kept mental illness in, but theoretically it doesn't have to be there. The critical issue is functioning, basically. So if you use that type of logic and apply it to adults, it's about 13 million adults, and we know it's 5.8% of the population. And that number doesn't vary from state to state or county to county. That's a very consistent number. So I would say in Pennsylvania, you're going to be either somewhere between 5.7 and 5.9 if you use that particular definition. I worked with Ron Kessler, and we actually tested that. For children, data is much worse. There's only been one epi-study on children's mental health, and that was done by Ron Kessler as part of the National Comorbidity Survey 2. So he actually had a sample of children in treatment, and he had a sample of children in schools, and we funded his sample of children in schools. And some of that initial data has now been published, finally. About 8 million children would qualify for what we talk about in this field as being children with serious emotional disturbance, or about 10% of the child population. Then the overall numbers, and you know these well because they've been consistent over 30 years, 55 million or 25% of the adult population has a diagnosable mental disorder in a year, whether or not it's diagnosed. If it were diagnosed, it would be diagnosed. And that's about 25% of that population, and children about 16 million or 20% of the population. So you're dealing with phenomena here that are very large, and the phenomena are very robust. The fact that those epi numbers for adults haven't changed for 30 years is very telling. And there have been completely different methodologies. So the original epidemiologic catchment area study done partly at Hopkins by Mort Kramer and other people, and Yale and St. Louis and so on, found the same thing. Ron Kessler's Comorbidity Survey 1 found the same thing. His Comorbidity Survey 2 found the same thing, basically. So these are very robust phenomena out there. In services, about a third of adults and 2/3 of children who have more serious disorders receive no care in the United States. So about 2/3 of the people with adults with serious mental illness do, and in Philadelphia I'd expect that number to be higher. Trevor and I talked about that this morning because you have a very good public system in Philadelphia. So it's probably actually much higher than 2/3, but nationally it's only about 2/3. And for children, the system has never reached as far out there. Mental health was basically an adult process into the 1980s until people went and lobbied on the Hill and got children's programs at NIMH. So prior to that, it was only adults. So children's services are a very late comer to this process. And as a result, a significantly smaller proportion of children ever receive any care. So it's only about a third of those children. And then if you look at other people, it's about 2/3. So adults with other mental illnesses, about 2/3 of adults who do not have serious mental illness but have other mental illnesses don't receive any care at all in a year. And you could go a little farther and say, well, how many people only come to care once and we never see them again, and you get into all that issue basically. Substance use, picture is even more bleak. Every year, about 23 million potential cases, and only 2.3 million receive any care. Most of those 2.3 million are paid for by the Substance Abuse Prevention and Treatment Block Grant. So it's absolutely critical we make the transition in the Substance Abuse Prevention and Treatment Block Grant to insurance for these people. Why is that the case? Because systematically people with substance use conditions were excluded from Medicaid beginning in 1998. the Clinton administration and Donna Shalala said, okay, going forward, no longer can people with substance use conditions qualify for supplemental security income or Social Security disability insurance because of their substance use condition, which meant if you don't qualify for SSI, you can't get Medicaid. You don't qualify for SSDI, you can't get Medicare. So what's happened then, we've got a huge pent-up demand in that population, basically. I did some work on Medicaid and Medicare data over a period of time. What that data showed for substance abuse for adults is that although about 11% of the people covered in Medicaid were people with mental health conditions, only 1% to 1.5% were people with substance use conditions, which flies in the face of what you know about the epidemiology of substance use problems in the community. So there's a huge pent-up demand. That problem should be able to be addressed through things like the Medicaid expansion, where substance abuse care must be offered at parity in the essential health benefit, and I'll come back and talk about that a little bit. The criminalization, another issue here. So in our discussions today, we said, well, you know, a lot of these people mental health clients left the state hospital. Where did they go? Where are the substance use clients? Where are they? They're in the jails, a huge number, basically, in the jails. And county jails have 885,000 people every night, and 70 to 75% of those people are people with behavioral health conditions. Not all SMI, but huge number with substance use conditions, smaller number with mental health conditions, and smaller number who are adults with SMI. That's a huge problem because in the county jails, the whole cost of the care is borne by the county. Under federal law, and if someone comes and they need care, it must be delivered under federal law, basically, the same way a federally qualified health center has to deliver care to whoever walks through the door. So we would like to do a better job of covering people with insurance who actually end up in the jails and are working on that issue. Wellness models. So 35 years ago, we thought that health and disease were the two ends of the same continuum. So here you have illness, here you have health. And all of a sudden there was the realization, well, that probably isn't correct. There are probably at least two, maybe more, but at least two dimensions here. One is a dimension of illness, and another is a dimension of wellness or health, basically. As soon as you move from a one-dimensional to a two-dimensional world, you have lots of new possibilities. Because I can have somebody who's very ill, way over here, but they have a very healthy outlook. That very healthy outlook reduces and mitigates the negative effect of their illness. And there are studies done over many years that support that type of idea, basically. So this also allows me to locate virtually everybody in this room is locatable somewhere in this matrix. And you can think, where are you yourself in this matrix, basically? And why are you there, and how would you move to a better place? Obviously, your goal would be to be up here somewhere. So what if you start down here? A lot of adults with serious mental illness start down here. How do we go from down here to up there? So I think, again, part of what the Affordable Care Act will be doing is working this model. So if you take this and actually apply it, an application of that model would look like this. You got the same thing. You got illness here. You got health here. So we start with people who have high morbidity and mortality. And I can work through biopsychosocial interventions horizontally. And I can work through self-help, social support, unhealthy lifestyle vertically to move toward recovery and health. I need to do both. So the implication of the two-dimensional model is it isn't adequate simply to do this. You got to do both here. So if I want to go from here, lower right to upper left, I need to do both. And I think what we've been doing unknowingly is adding this dimension. We started here. This is where mental health was 25 years ago, and we've been adding this. And we've been adding this mainly because the consumers are demanding that we add it. And again, this has huge implications for what we would design going forward here in terms of prevention. Where would you put prevention in here? So if I take that model and say, well, the first step on prevention is if I don't have a condition here, but I'm in this quadrant, I'm an adult with SMI who has schizophrenia, but I don't have diabetes or I don't have heart disease, how do I prevent that person from getting diabetes or heart disease? And I think that's where the public system is going to start with this. And over time, you're going to end up over there working with people who don't have any of these conditions. And you need, and a logic needs to be evolved to move from one side of this model to another side of the model over time. What are some of the implications? Provision of primary care is essential in that model. Provision of substance use care is essential. Provision of mental health care is essential. Facilitation of wellness and recovery approaches is essential. So all of these become essential pieces in what we're doing. And care integration has become a mechanism by which we might go about doing this, basically. Hence the point here. Okay, now I'm going to go to stage 3, which is the Affordable Care Act, talk a little bit about that. So the 3 pieces I'm going to talk about are insurance reform, coverage reform, and quality reform. I do have an article, so you can have a choice. So I'll give you the 2,300-page Affordable Care Act. You can read that tonight. Or you can give you my 10 pages of Cliff Notes article, and you can read that, and you'll probably know about as much as if you read the 2,300 pages. So, okay, so there are 5 types of reform here. Insurance reform, coverage reform, quality reform, payment reform, and IT reform. I'm really only going to talk about the first 3 here. So insurance reform. ACA will provide personal health insurance to 39 million adults. We believe, based on EPI work we did in 2006 and 7, that at least 11 million of those 39 million people who currently don't have insurance already have a behavioral health condition. And probably 60% of that 11 million are people who have a primary substance use condition for the reason I mentioned earlier, because they've been excluded from the system historically. So the prevalence of behavioral health conditions here in this population is about 30%. It's a significant prevalence. And that's probably partly due to this pent-up demand. It's actually higher than if we did a straight prevalence analysis. So the new insurance intended to cover 39 million adults in 2 mechanisms. The state health insurance marketplaces, and you've been reading for many months about healthcare.gov. So, in the marketplaces, there's a very long and complex discussion of market. There are 3 kinds of marketplaces: federally facilitated marketplaces, state partnership marketplaces, and state-operated marketplaces. 37 are federally facilitated or state partnership, which means, in effect, the federal government is doing most of the work. The balance are state-operated marketplaces. So an example of a state-operated marketplace nearby would be Maryland. Maryland has a state-operated marketplace. The marketplaces began on October 1st. They had huge problems with healthcare.gov. They've more or less overcome that now. My latest understanding of the number of people who were enrolled, as of the end of December, they had enrolled approximately 2 million people through the marketplace nationally. So if I count the federally facilitated, the state partnership, and the state operated, it's about 2 million people. Those marketplaces will continue operating till the end of March. Then they will close. So if you know people who need to be enrolled and they are not enrolled, they may extend it by a couple days, but they're not going to extend it by months. So they must be in that process before the end of March. Then the marketplace will pick up again. I believe it's on October 15th, and we'll go through another cycle at the end of 2014. Enrollment in the marketplaces is not continuous. That's one principle here. Another principle that's very, very important: if you are in a state that is not doing the Medicaid expansion, Pennsylvania is not doing the Medicaid expansion, your marketplace doesn't just extend down to 138% of poverty, it extends down to 100. So about a third of your population who would have enrolled in the Medicaid expansion are being picked up in the qualified health plans. The issue will be, are those benefits sufficient for all those people? How many people in that group are what would be defined as medically needy? And there's a principle for those who are medically needy. If people are identified as medically needy and you were doing the Medicaid expansion, they would be moved over immediately to traditional Medicaid. Disability Medicaid, basically. And states that are even doing the modified version like Iowa, where everybody above 100% is going into the marketplace and under 100% is going into Medicaid, anybody above 100% that's discovered to be medically needy is moved to traditional Medicaid. So your gap population will not be as big as it would be had these people from 100 to 138% of poverty not been included. Medicaid expansion, by contrast, was intended to cover everybody below 138% who was not currently insured. And unlike traditional Medicaid, it didn't require any other qualification other than income. So it changes the nature of the Medicaid program, which has been a program-oriented system, to just a much more straight insurance-oriented system. And it's a different set of people. You have no reason to believe that everybody who would enroll in the Medicaid expansion will need health insurance, will need health care at the time they enroll. Some portion will, but not everybody. It's more like a traditional insurance population. Essential health benefit, another term you should know. So the essential health benefit is a set of 10 benefits that every qualified health plan in a marketplace must offer, including mental health and substance abuse, which must be at parity. Having said that, every state was given a choice and say, you choose from the following 10 health insurance plans. You choose from the 3 largest federal employee health benefit plans, the 3 largest state employee health benefit plans, the largest HMO in your state, or the 3 largest small business plans in your state. You pick one of the 10. If you don't pick anyone, then you default to the largest small business plan in your state. And that's not a good outcome for us in behavioral health care, because we know historically that the behavioral health benefits have been pretty weak. Pennsylvania defaulted to your largest small business plan in this state. And I actually called that plan to ask them about it, and they didn't even know that they were the plan that was selected. That was quite a while ago, so I don't want to be unfair. That was like last March when I found out who they were. I called them and asked them, tell me about, the benefits you're going to, well, they didn't seem to know anything about it, which says something here. So the grand challenge here in this area is how we're going to enroll those 11 million people. That's the grand challenge for us. And so the challenge for you is you need to be involved in enrolling people in insurance. I'm very serious about that. It's like my colleagues who are county directors. I want every county director out there enrolling people. Many of the people who are eligible and need this insurance don't have a clue about insurance. They don't have a clue about enrolling. They couldn't operate the healthcare.gov website, and I just go on and on and on. You need to help them, basically. Otherwise, what will happen is that population will be left behind. And the proof of that is in Massachusetts, 8 years after they've done this, there's still about 3.5% to 4.5% of the adult population in Massachusetts not enrolled in insurance, and the bulk of that group are people with behavioral health conditions. So the proof is there. We need to help these people enroll, basically. So, second area is coverage reform. So I told you already, the ACA eliminates pre-existing condition clauses in health insurance, as well as annual and lifetime limits. So the annual and lifetime limits went away on September 23rd, 2010. So prior to that, every one of you in your insurance plan probably had a $1 million annual limit that's gone now, basically. And the point for us here in this is that everybody who has a behavioral health condition has a pre-existing condition. Yeah, please.
So the annual lifetime limits, did that impact Medicare as well?
It I think, applied principally to private insurance.
Okay.
Now, one of the issues with the Affordable Care Act, many of the things I'm talking about in the Affordable Care Act don't apply to Medicare. So, for example, parity, the way I talked about it, doesn't apply to Medicare. However, having said that, Part B Medicare, annual co-pays for mental health, finally, on January 1st, fell to 20%. We worked on that in 2007, and it took 7 years to get it to go from 50% to 20%, basically. Yeah. So many of the things I'm talking about here do not apply to Medicare. There's a whole huge agenda of working on the future of Medicare, basically. And then the only other thing to mention here, I guess, is the people 26 or less. So everybody 26 or less can remain on their family policy. That's been huge because half the people coming out of college do not have jobs. And under the old system, their insurance would have stopped. So now there are about 3 million people enrolled in family policies because they're under the age of 26, basically. And then finally, no co-pays or deductibles for any prevention or promotion activities. So if you have an annual physical in your insurance policy, there can no longer be a co-pay or deductible for that. So the grand challenge, how can we spread the word broadly that we have your back if you have a behavioral health condition? We're not going to let you hang out there with no insurance because you've been deliberately excluded, or you have no benefits. And we need to communicate that. And the difference for us in behavioral health care, and I've been in the field 40 years, is that mental health always began where the money was. So if the money was there and I moved it over here, we'd be over here. We were over there. We never began before the money saying, how do I generate this insurance, or how do I generate this coverage so that the money is over there later on? We're going to have to change. We're going to have to understand insurance. We're going to have to understand coverage and who's covered and not covered and all these things, not just study the healthcare system or delivery services. This whole problem and effect of the epidemiology of insurance is going to need to become part of our world here. And that's going to be a huge change for us because you can probably count on one hand the number of mental health economists who deal in this area, people like Richard Frank. So the third area here is quality reform. Quality reform is about moving the system to integrated health homes, basically. The ACA provides for the creation of integrated health homes which offer prevention and promotion as well as care. Could have a long discussion about that. The Affordable Care Act, Section 2703, allows states to create state plan amendments to their Medicaid plans to create health homes for specifically defined populations. So, for example, I could go in Pennsylvania and create a health home for adults with serious mental illness for Philadelphia. It doesn't have to be statewide, it can be one population. And there's a whole listing of populations, and that issue came up several times today as well. So I'm going to send Christina a set of overheads on Section 2703, and I'm going to actually send her the letter that CMS sent out to the field announcing this program because it's obviously relevant to a lot of work that's ongoing here. In this, so there's another term to be introduced, in creating health homes are going to be run and operated by accountable care organizations, ACOs. So if you want to see where the puck is going, you need to look who in Philadelphia, who in this county, who in this area of the state is creating ACOs. And what role do you have in that ACO, and how are you going to get yourself to the table of that ACO? Now, in Medicare, the only entities that were allowed to create ACOs were hospitals, primary care practices, federally qualified health centers, or rural health centers. That's not true in Medicaid. Medicaid is more open. So behavioral health entities can actually create ACOs in Medicaid. They can't in Medicare currently, under current Medicare regulation. We fought against that in the Coalition for Whole Health, and we lost on that particular issue. So you need to have a little, and ACOs can be either an umbrella organization that has several other organizations under it, or it can be a whole new organization that's brought together here. The federally qualified health centers were just given $57 million, a couple days was their Christmas present actually, to bring in behavioral health services. So the advice is on the FQHCs, if they're bringing in behavioral health services, you do not want them to build those behavioral health services. You want them to work with the behavioral health services we have. And Mary Wakefield, their manager, wants that to happen, but we need to go to the table. We need to be at the table on this. And if we don't do anything, they will build those services independently, and then they'll compete with the behavioral health services that are currently available. These accountable care organizations are going to be responsible for quality measures. We could talk many, many hours about the morass of quality measures in the United States, just an absolute morass. It's probably more disorganized than any other piece here. And I could easily probably enumerate 500 quality measures, and we all know that's ridiculous. So I think that piece is going to have a very difficult time developing here because there's absolutely no consensus on the issue and everybody has their own quality measures. CMS, SAMHSA, ARC, they all have their own quality measures. So the grand challenge here, how can we foster the development of health homes and ACO without losing many of our providers along the way? So the mom and pop, going to be gone probably. Can't make the adaptation to electronic health records, electronic billing, just the logistical things, let alone the conceptual and philosophical transitions that are involved here. So I expect a lot of the behavioral health entities to disappear as we go through the next 5 to 10 years. Now, that doesn't mean the people who work there aren't going to be working in behavioral health. They're just going to be under new management. Yeah, exactly, exactly. So we need to be very careful and attentive to what we want to keep and what we can afford to lose here. We don't want to wake up 10 years from now and lost all the gains we've made in the last 10 years on concepts like recovery and wellness and resiliency and so on. Payment reform, moving from encounter-based systems to case and capitation rates. Trevor's smiling because he and I have been talking about case rates for 25 years here. Well, there's actually hope that these things are going to arrive here now. First, case rates per person served, and ultimately capitation rates per person covered. And we're going to have to learn how to self-manage with case rates. Huge issue. I gave a seminar over in New Jersey on case rates about a year ago, and it was about 100 people in the group from the county systems in New Jersey. It was very obvious to me that they had never thought about these concepts before. We need to be thinking about that. There needs to be research on these issues of case rates. You know, what is an appropriate sub-case rate for mental health in a system serving adults with serious mental illness who have schizophrenia? I'm not sure we know the answer to that, or even an easy way to get to an answer of that, basically. In IT reform, the ACA assumes that you have electronic health records. It doesn't say, I'm giving you money to get electronic health records. It says, if you have electronic health records, I will enhance your payments if you use them to report federal data, and so on. We are at the starting gate over here. We haven't taken the first step. We are working on some separate legislation, and the legislation has been introduced in the Senate by Senator Whitehouse, which would extend the grants for IT, for electronic health records, to behavioral health organizations. And we think we have a reasonably good chance of getting that passed because it isn't controversial. The Democrats believe you can save money with electronic health records, and the Republicans believe that. So there's a huge issue for us here of getting ourselves up to the starting gate of the Affordable Care Act. So we're in the last round, not in the current round on that particular issue. So moving on then to kind of the next phase here, solutions are emerging, program level solutions, evolution of the health home, which is kind of where I started. So we had treat, refer. We know treat, refer didn't work. Obvious, people never ended up at the referral. Bidirectional integration probably works somewhat, is not sustainable because it's being funded by grants. If I pulled the plug on the grants, the balloon would go down. Doesn't address at all the issue of the huge population in primary care who come in with behavioral health conditions where the behavioral health conditions are the aggravating conditions. And then full service integration, which is what the paper talks about, so I'm not going to really go through that. I know you're going to read that paper tonight. So, let's see. State level, weakening of the state mental health and substance use agencies, what's going on there, strengthening of the state Medicaid agencies. So if you go forward, your new partner out there, you need to be talking to the state Medicaid director. You need to be talking to the state health insurance commissioner. How many of you know who the state health insurance commissioner is in Pennsylvania? Trevor may be the only one here who knows that person here. An emergent model of patient-centered and whole health care. So the states, I think, really pretty much buy into this. This is not controversial anymore. Integrated care reduces costs and managed care reduces costs. And that's why I think the ACA is kind of doing integrated care and these 1115 waivers are doing managed care. We've got to bring these together someplace. They can't continue to operate here as parallel systems. And so business as usual is not an option. So it's very obvious. The kinds of research that are done in this department are going to change as a result of what's happening here in the Affordable Care Act. You're going to do a lot more work with prevention and promotion, as I said. You're going to be doing a lot more work with primary care services. Going to be doing a lot more work out there looking at population level interventions. Behavioral health is going to have to become much more a public health discipline and so on, basically. And providers, what can providers do? So if we get into this, I think, we're down to some very basic things. So every provider should be doing some of these basic things. Assessing people's weight, their body mass, their blood pressure, and their blood sugar. If we simply did those 4 things, that would make a huge difference. And I believe you are already doing many of those things in Philadelphia. So the message really is not for you here. Care and prescribing meds. We could have a very long discussion about second-generation meds and their tremendously bad side effects here, basically. Use wellness regimens. I bet you almost all of you are involved in some kind of a wellness regimen in your own life at some level. You walk, you exercise, you don't smoke, you try to eat healthy foods. Well, the same thing applies here in this context. Engage and use prevention and positive health interventions, and we've got a long way to go to develop positive health interventions. So what do we expect? If we do these things, we'd expect longevity to improve. That 25-year number that we developed in 2006 on 2001 and 2 data should change. That's the most fundamental outcome measure I can think of. If that number doesn't change, we need to ask why that number is not changing. Improve community tenure. So people in and out of the state hospitals. Not a good outcome here, basically. Improve community participation, that you actually have a house, a place to live, you actually have a job, and you actually have a social support network in the community. 3 fundamental things. And then, if we can do some of this at the personal level, we need to figure out how to do it at the population level. And we could have the same kind of comments about population level interventions here. Greater attention to social and physical determinants of health. You have one of the experts here, and Dr. Kumanika, in the social and physical determinants of health, addressing health disparities because of problems in the social and physical determinants. more community participation in addressing local health issues, less stigma in the community, much greater recognition that all health and health care is local. In the end, if I had a heart attack right now, I would live or die depending on how good the care is in the hospitals around here. It has next to nothing to do with Obama or what the governor of this state is doing. It has to do with what's going on right here and how much the people in this community care about what's going on right here. So some likely future topics here: integration of health with public health. I mentioned that in the beginning. Positive health promotion. How do you positively promote mental health? Not address disease or prevent disease, but promote positive mental health in somebody. Personalized care with customized drugs. We literally talked about that. Debates about genetic engineering. So if I stood here and said in 5 years we're going to be able to engineer genes that I can engineer any genetically based schizophrenia out of the population, how would the mental health system respond? That's the issue here. We don't ever talk about this. We need to begin talking about this. This stuff is literally just around the corner here. So we're on the right side of the issue. We have services that can decrease health disparities and promote equity, and our clients can and will become productive citizens in a global economy. So with that, I'm going to stop and see if we have any comments or questions anybody wants to raise, and we have about 20 minutes or so, right? Yeah, okay. Good, okay. Yeah, please.
Two questions, I'll try and make them brief. Could you comment on the Stephen Brill article? I guess it was a whole Time magazine thing about a year ago that discouraged me, because I think the Accountable Care Act has some very nice things to it, but Brill seemed to suggest that it's just nipping around the edges of the problem, which is not controlling the profits of the so-called not-for-profit healthcare system. And the second question is,
okay,
why is enrollment not continuous?
Why is it a 6 month break?
well, so your first question, it's very interesting. So Shriki will think this is interesting too. So after the Affordable Care Act was passed, I gave a talk at the APHA meeting on the Affordable Care Act, probably in 2010. And the people in the room were kind of disappointed. And so I said, well, why are you so disappointed? They said, we wanted to have single payer. We wanted to have single payer. So you get into the issue here of what is reasonable to be accomplished at one point in time versus what is too idealistic, and you're probably realistically not going to be even talking about single payer for 25 to 50 years. You may get it eventually, but you aren't going to get it right now. You got to take what you can get. So Franklin Roosevelt, when he did the Social Security system, the advisors came down from Harvard and said, you have 3 problems here. Problem 1 is Social Security for the elderly. Problem 2 is health reform, and problem 3 is welfare reform. The political advisor said, you're never going to get these 3 through the system. Pick one. Do the others later. He picked Social Security. Never did the other 2. Now it's, 70 years later, we're working on number 2. So you got to phase yourself a little bit because it's simply not feasible to be done. Yeah, please.
How you see the manpower, person power involvement, in terms of shortage of psychiatrists, growth of psychiatric nurse practitioners, people who can actually do short-term therapy and have Alzheimer's.
Yeah, understand.
Any combination.
So I think human resources are a major issue. Cynthia has worked on that issue here for many years, and in Delaware and elsewhere. So in behavioral health, we have several issues to put on the table here. One, the managers we have are all baby boomers. So all of those managers, county managers, some of the state managers are going to be retiring clearly in the next 10 years, some in the next 3 to 5 years. That's a huge issue for us because the next generation down is what I call the baby bust generation. There's nobody there because they would have come into the system at the time Ronald Reagan was the president, and they said, my God, I can't go into this field. I have to go into law or something else. And they didn't come, or business. They didn't come to us. So we have the baby boomers leaving. We have a baby bust. And then we get down to, let's say, 40 to 45 years old, where we have people who are going to be assuming major management roles with very little training. So part of what I offer at Hopkins is in effect a course for emerging county managers who wake up one day and their boss says, I'm leaving on Friday after 35 years, you're in charge now. And they say, oh my God, it's those people.
Increasing the mental illness in there.
Yeah, so that's a huge issue for us. Even if there were no Affordable Care Act, everything I just said would still be true. Now with the Affordable Care Act, we're going to have to generate a whole set of new people to work in primary care settings. A huge number of people. There are no obvious federal mechanisms of generating those clinicians. We're going to have many new roles for peers, and I gave you a little commentary on peers for that very reason, that we haven't even begun to define the role of a peer in an integrated delivery system who works with somebody who doesn't have any behavioral health conditions. So there are tools that we need to be evolving here. We need to be working with Mary Wakefield and the money she did get for training to say, you know, we need to do more with the National Health Service Corps. National Health Service Corps trains about 12,000 people a year, 3,500 of which are behavioral health, psychiatrists, psychologists, or social workers. There's much more that needs to be done. Human resources is like furniture in a depression. Nobody ever wants to talk about it. And it's very hard to generate any conversation about human resources in behavioral health because you immediately confront the issue of the disciplines competing with each other. But you're absolutely right, that is a huge issue. We need to have more and more focused discussions among the national organizations on that issue going into the Affordable Care Act. Absolutely correct. Cynthia, yeah.
Could you just say a few words about, I work with Peggy Swarbrick on wellness.
Okay.
And one of the tensions that I see kind of building is that, for example, they want to look at blood pressure within wellness centers and wellness recovery services. And so they say, well, we'll just take blood pressures. And I say, well, then I think we're like butting up against what are nurses allowed to do?
Yeah.
And what are non-nurses
Right.
allowed to do?
Yeah.
And do you think that that will become an issue as we look at this sort of prevention wellness piece?
Well, I think we're going to have to develop ways to extend what physicians and nurses do. And
Only
so,
through them or extended?
well, through either system, we need to figure out how to extend the capacity of these people through appropriate training. If I train you appropriately, there's no reason why you shouldn't be able to take people's blood pressure.
Exactly.
And otherwise, it's simply feather bedding, basically.
Yeah.
Yeah, no, I'm with you. But we need to begin
But it needs to
making,
be,
yeah,
like,
exactly.
there's a dialogue. that
Yeah,
needs to be-
exactly. We need to start that dialogue, yeah.